Hello and welcome to Anatomy Review. This is the second part of the Basic Life Support Clinical Anatomy. My name is Dr. Cobb, and I'm going to start off just by looking at the osteology of the thoracic region and just talking about basic life support in relation to anatomy and physiology, just so we can kind of get a better understanding. This series that I've made is for clinicians and for laymen alike, and it really is just a kind of overview of basic clinical anatomy, physiology, and relating that to basic life support. So in this model that I've made for you here, by the way, all my models are freely available on Remix 3D. If you just go under anatomy or clinical anatomy, you'll find my models, and I'm also going to put up a link so you can have a look and use these. These are 3D printable, so you can use these for teaching, learning, and you can also share these, adapt them, and use them for any purpose that you see fit. So what I've got in this concept here, in this model that I've made, so what we can see is here we have the vertebral column, the thoracic vertebral column. There's 12 vertebrae in the thoracic region, as we can see here. We've got these grey areas that I put, which are IVDs, intervertebral discs. And then, of course, this area here is the thoracic region, and this would be where we would see the heart and the lungs, which we're going to talk about in relation to cardiopulmonary resuscitation. So on the anterior chest wall, we have the actual sternum itself. The sternum is a composite. It is different parts of the sternum. So we have the upper part of the sternum, which is the manubrium. We have the body of the sternum, and then we have the xiphoid process on the lower region. And some of the important points that we're going to talk about in relation to clinical anatomy and basic life support are some of the regions that we can see here. So what we can see on the upper part in this region here is the jugular notch, or the sternal notch, which you can feel on yourself or indeed your patient. Very palpable point. And this is a really important point, because when we just turn the model around to the side and just zoom out slightly, we can see that the jugular notch lines up quite nicely with the level of T2, second thoracic vertebra. This is a really important level because just two more vertebrae underneath we are in line, so T4, the angle of Louis, or the sternal angle, which I've just put here in this model as a little gap. Now this is a really important point in clinical anatomy, basic life support, intermediate life support, and advanced life support, and in fact in just general understanding of anatomy of the thoracic region. So T2 in line with the jugular notch on the anterior sternum, T4 angle of Louis. Angle of Louis is really important. This T4 level is really important because we have so many structures that are kind of integrating themselves together at this point. So if we just imagine, just for a moment, we've got this osteology here, we've got the bones. So if we were to just dress these levels, which we're going to do, and just add some of the structures, the first thing that we're going to have over this is the anterior longitudinal ligament, this ligament that just kind of covers over here, over the bone. Then in front of that, we're going to have the esophagus, which the esophagus is coming down, roughly down the midline. Then it migrates off to the left, and it breaks through the diaphragm. And the diaphragm is going to be here on in the level of T9. We have the central region of the diaphragm, central tendon of the diaphragm, and then the right and the left cupola of the diaphragm. And the esophagus, which is going to be immediately anterior to anterior longitudinal ligament, coming down, and then is going to break through, and then of course is going to unite with the stomach. Then in front of that, anterior to that, we have the trachea. Now the trachea is going to come down roughly in the midline. Then the trachea at the level of T4 here is going to split into the right and the left primary bronchi. And I'm going to just show you that with my next model in a moment and just show you the relationship of that. And then I'm going to talk to you about some clinical things such as complete partial airway obstructions and how these manifest in your patient or in our patients. Now, also at this really important level, we also have the arch of the aorta, and the arch of the aorta giving off the great vessels of the superior mediastinum. So the arch of the aorta is going to be arching over in front, anterior to the trachea. So kind of just relationship, if we just look at the relationships just for a moment, we just quickly go around. So if we just think about the vertebral column, just look at it on anteriorly just for a second. So we're going to have the anterior longitudinal ligament dressing over this osteology of the vertebral column. In front of that, we're going to have the esophagus going down and then kind of migrating off to the left, going through the diaphragm. Then in front of that, we're going to have the trachea coming down and then splitting into the left and right primary bronchi. Remember, of course, this is giving in to the lungs, so this is the airway communicating with the lungs. And then, of course, in front of this, we're going to have the arch of the aorta. So there's a whole lot of stuff that's going on around this region. So whenever you palpate on the anterior chest wall and you feel this sternal jugular notch, roughly 2 to 3 fingers underneath, you have this other landmark that you can feel, can palpate, T4. You can think from your anatomical knowledge that there's a lot of structures on the inside at that level, which Okay guys, so what we can see in this next concept model is we can see the osteology or the osteological model now with the heart added. So we can actually see the position of where the heart is in relation to those thoracic levels that I was talking about. So again, from the side view, T2, T4 jugular notch in line with T2, T4 roughly in line with the sternal angle, the angle of Louis, and we can start to see some of the structures. I haven't got the esophagus and the trachea in here yet, but what I do have is I have the heart and the position of the heart approximately where it would sit. What you will notice is in real life that the heart would be much nearer to the sternum, to the chest wall, and of course when the lungs are in place and the lungs are inflated as well, it's much closer within this thoracic wall. What I really just wanted to show with this concept is I haven't got the diaphragm in, but where the diaphragm would be on the level of about T9, so T9 here, T10, 11 and 12, we'd have the central tendon of the diaphragm, and essentially the diaphragm is going to then form the floor that the heart sits on within the thoracic region or the mediastinum. What I've done here is I've added a few structures of the heart. So we can see here the aorta and the arch of the aorta, and then the arch of the aorta comes down posteriorly. It goes around the back of the heart, and as it comes down, it goes behind the diaphragm. It doesn't actually break through the diaphragm. It goes behind the diaphragm, and then it actually re-emerges at the point of T12L1 where it becomes the abdominal aorta. But what I just wanted to emphasize here is the relationship of the arch of the aorta and then the great vessels of the neck. So we can see the carotid and the common carotid, internal and external, giving rise to the arterial supply to the head. Now, when we're talking about basic life support and we're talking about chest compressions, we're talking about interthoracic pressure, we're talking about pressure going on the sternum, pushing through the chest wall into the heart and essentially pumping blood to the brain the same way as the heart does rhythmically with the contractions of the heart through the sympathetic and the parasympathetic nervous system. And of course in basic life support what we are doing is we are mimicking the blood supply to the brain. So every time that we compress on the chest wall, we're pressing down, pressing upon the heart and ejecting blood up to the brain. What you will notice here as well on this concept model, although we are discussing just the basic concepts of basic life support, I've just added here the vagus nerve, which comes down through the carotid sheath, following the carotid artery, and then of course looping round where it becomes the recurrent laryngeal nerve, which we can see here and then of course on the other side it coming and looping around in a similar manner, although not arching around the arch of the aorta on the right side. So really what I just wanted to get across with this model and this concept is a few key points. Just these thoracic levels, T2, jugular notch, sternal notch, T4, angle of Louis, a lot of stuff going on. And then of course posterior to this we're going to have the trachea, which we're going to see in the next model, and then of course posterior to that we're going to have the esophagus, and then covering this of course the anterior longitudinal ligament. All of this is going to be the floor, which is going to be the diaphragm, which we're going to talk about in some later videos when we talk about the divisions of the superior mediastinum. And some other important points such as that. Okay guys, now in this this final concept I have added the heart and the lungs to the osteological model, my concept model. So now what we can see is we can see the relationship. So this is just a follow on. Let's just quickly just recap. T2, T4, angle of Louis, sternal angle, jugular notch. Now what we can see is we can see that we've also got just next to the arch of the aorta and posterior to the arch of the aorta we have the trachea. So here we have the trachea and the right and left primary bronchi, and this bifurcation of the left and the right primary bronchi. What you'll also see here for some of my medical students and my other allied healthcare students who do cadaver labs with me, you'll see the left lung and the right lung, and of course left lung we have the 2 lobes, the right lung we have the 3 lobes, and then what I've done here is I've just drawn on the left lobe. We can see this kind of indentation point. If I can just zoom in for a moment, we can see this indentation point of where the arch of the aorta and the descending thoracic aorta makes this indentation into the left lung, which you can see in the cadaver labs when you remove the lung from the cadaver. So again, just relating all of this to cardiopulmonary resuscitation, to CPR, I really just want you to think about a few key points here. Basic life support, and I guess I'm just going to touch a little bit on intermediate life support and symptomology as well. Just remembering that the floor formed by the diaphragm at the level of T9, T10. So when we are performing CPR, compression upon the sternum, which is producing interthoracic pressure, which is essentially mimicking the rhythmical movement of the heart, thus transferring blood through the great vessels into the head, and also moving the lungs as with inspiration and expiration. And as I briefly talked about in the first video, where I said that in basic life support it may not always be possible to manage the airway, we can still perform chest compression. So this interthoracic pressure is still going to build up pressure within the thoracic region, which is going to allow blood to continue to the brain, because remember 2 to 3 minutes without oxygen to the brain, and it's got irreversible brain damage. But by doing these compressions we're still mimicking the action of the heart, getting blood to the brain and still getting some oxygen into the blood as well by the process of pumping the lungs as well. What I want to do over the next few sessions is I really want to kind of go into more clinical anatomy, and in my presentations I shall go through more of the material that I lecture to the medical students and some other allied healthcare professional students. But I really just want to share these concept models that I've made, which, as I've said before, they're free to share, free to use, free to adapt. I hope they're useful. I really hope that you find some use for them in your clinical teaching, learning experience. And please